Hello and welcome everyone to today's webinar. We appreciate you joining us today. We're going to be talking about SBIRT in various settings, differences and common threads. I'm Tracy McPherson and I'm your moderator today. I'm a senior research scientist in the Public Health Department at NORC at the University of Chicago. I'm also the Training, Technical Assistance, and Evaluation Lead on the SBIRT projects at NORC. If you have any questions about today's webinar or any webinar in our series or the work that we do as part of the National SBIRT ATTC, you're certainly welcome to contact me at any time. Today's webinar and all of the webinars produced in our series are produced in partnership with the Brief Intervention Group, or the BIG Initiative, NORC at the University of Chicago, and the National SBIRT ATTC funded by SAMHSA. Our website is www.sbirteducation.com, and you can access a lot of resources as well as all of the materials for all of our webinars, and including our on-demand webinars. So I encourage you to take a look. We have lots of resources, articles, screening tools, a lot of things that would be very useful to you. So check it out if you haven't done that. So today's webinar, as I mentioned, is part of our 2017 SBIRT webinar series. As you can see, we've been underway for a number of months now in this series, and this series is really one that's offering a couple of new things this year, including looking at special populations. And one of the things that we've done is put together a mini-series, our IPV mini-series, or Intimate Partner Violence mini-series. And you can see that we have 3 of those, and you can access all 3 of those through our hospital sbirt.webs.com website. You also will receive, if you haven't already, in our newsletter, a link to the mini-series where you can access all 3. You can also look at any additional materials on our website related to IPV, and also you can receive continuing education credits for participating in our on-demand series. Coming up in June, we have another special topic, which is looking at SBIRT for problem gambling in military populations. So I encourage you to sign up, share information about our webinar series with your colleagues. You can download a flyer. All of these webinars are available on our website, and all are available on demand. Today's webinar has its own dedicated page, like all of our webinars. You can go to the hospital sbirt.webs.com website. You click on the webinar, and you will access all the PowerPoint slides for today's webinar, any materials and resources. So if our presenter mention something that might be a particularly really good resource related to one of the topics or questions today, and we want to post that, you can always find it posted back where the original PowerPoint slides are located. In addition, we will also be recording today's webinar, and we will put the on-demand recording up on the webinar page as well. And in addition to that, after our webinar, we will be sending you information about how to request a certificate of completion, how to complete the evaluation, and any other information that you might need. And again, you can access all of this at our hospital sbirt.webs.com website. If you're not familiar with the GoToWebinar control panel, typically located in the right side of your screen, there's an area in there called Questions Pane. And if you have a question at any point during the webinar, you're welcome to go ahead and get it in the queue. If you have any technical questions, administrative questions, questions for the presenter, all of them can go in there. I would encourage you, as soon as you think of your question, go ahead and get it in the queue, and we will try to answer as many of those questions at the end as we possibly can. Behind the scenes today and helping me host this webinar is our technical facilitator, Misty Story. If you have any of those technical questions or administrative questions, she'll be behind the scenes responding to you when you enter your questions into the chat pane, into the questions pane. And today really is such a pleasure to be able to have our presenter, Pam Petraszewski, who I certainly have been delighted to get to know over the last couple of years, and listening to Pam in various venues share her experiences. And so it's really, quite a thrill for us to have Pam with us to share all of the wonderful things that we know could be very, very useful to all of you who are joining us today. And so I really, it's my pleasure to introduce Pam to you if you don't know her already. Pam is an integrated health consultant at the National Council for Behavioral Health. She provides training, coaching, and consulting to healthcare organizations across the country on motivational interviewing, SBIRT, and the integration of behavioral health, physical health, and substance use services. Currently, Pam is the clinical lead for the Reducing Adolescent Substance Abuse Initiative funded by the Conrad Hilton Foundation, which is being implemented in 28 organizations across 6 states. Previous experience in SBIRT includes serving as a project director for the St. Louis County 6th District Court SBIRT program, which was funded by the Minnesota Department of Human Services and the Minnesota Department of Public Safety, and also serving as the state lead for the Partners in Integrated Care Consortium, an ARC or AHRQ funded project in Minnesota, Pennsylvania, Wisconsin, and Massachusetts. Pam is listed in the National Registry of SBIRT Trainers for the Addiction Technology Transfer Center, or ATTC network, established by SAMHSA. And so I am thrilled to be able to welcome you, Pam, and I'm going to turn it over to you.
Wonderful. Thank you so much. It's a pleasure to get to be here with you today and to share some of what I've been hearing and learning throughout the years of implementing SBIRT in various settings. So a little bit additionally about the work that we've been doing at the National Council, if you're not familiar with our organization, that we have almost 3,000 member groups right now, and they are primarily safety nets and other community mental health, federally qualified health centers. We have some hospital members and others that work in the mental health and addictions field. And it's just been a real pleasure to be part of this organization now for about 3 years. And we do a great deal of work in the policy space and in practice improvement. And we also run the SAMHSA Center for Integrated Health Solutions. If you're familiar with that website, we also have a lot of cross resources with the ATTC. We also have what's called Mental Health First Aid, which is a very popular program and an important program to help people understand the basics of identifying and working with someone that might be having a mental health crisis, much similar to physical medical first aid. Additionally, I just wanted to mention that a big thing that we do every year is what we call Hill Day. It's one of the DC's largest advocacy days of the year. It's really important that we get the word out that we're always looking for more people to join us. Registration is free. You just need to get yourself to DC. And then we host a number of free courses from our Public Policy Institute on things like behavioral health policy, how to advocate and have meetings on the Hill. And, we're in a period of time where a lot is changing in the healthcare reform space. So we really are always looking for people to help protect Medicaid, secure behavioral health funding, and join us in DC for Hill Day in October. So with that, I'm looking forward to talking with you more about SBIRT in the various settings I've worked in. So this graphic is my attempt to kind of visually show that there are differences in some of the settings I've been able to help implement SBIRT and some commonalities. So I want to share a little bit of both of those with you today. And specifically, I'm going to talk a bit about some of the differing spaces in which I've seen SBIRT work. Particularly, I'm going to talk about primary care clinics, also in the judicial system and in community mental health centers, and how some of these locations have also engaged community partners to make SBIRT more sustainable, and how within their individual walls, how they've energized and engaged and found the right workforce and the workflows that have been needed to make this successful. So the first way in which I looked at this was that regardless of location, what seems to be the most common starting point is that a question comes up of feeling that we're impacted by substance use and how, based on our location, whether it be geographical or the type of clinical or other setting. And that can sometimes start with a gut feeling or a personal experience or even a professional experience of starting to sense that substance use is a problem and is a concern, and it's something that's impacting our stakeholders or our particular population. It's that idea of the burning platform that can really get things started, that this is an issue and we need to take some different approaches that might be spurred by the legalization of marijuana, the opioid epidemic. I've also had different people come to me and say, you know, we're a small town, but really the only thing in town is a church and a bar, and we're concerned that, you know, we've got people that are maybe misusing alcohol and it's affecting other parts of their lives. Or I've heard others say, well, we're a college town, and so we're concerned about the college students and binge drinking or other substance use. We've also had people say, you know, we're a big part of our economic livelihood or tourism has to do with alcohol or other substances. So different things will spur different conversations. It also might be an ethnic cultural experience type thing where someone will say, you know, we want to make sure that we are educating and supporting people around the substances that they're using because it's part of their cultural experience. So lots of different ways in which this starts. What comes next usually, or at least I encourage, is that following that question and that conversation, that there be some local data gathering. It really can help make the picture more crystal clear around what is the reality that we're seeing in our particular area or in our population. It can also help to prevent or dissolve some of the thinking that also comes up, which is kind of the flip side of all of those earlier conversations, that not in my backyard, or I don't think we have a problem here. And it can really rally then, what's number 3 there is it becomes then a shared problem with shared solutions, where various stakeholders, after looking at their data and having those crucial conversations, they start to see that this is something that is more than just the work of the clinic, or it's more than just the problem of the courtroom. So it's a really nice way of saying, how do we take this to a level where we've got a broader amount of stakeholders to help us really think about what is the right approach. So what I'll talk about for this webinar is really the experiences I've had in a lot of different settings. And you know, certainly my experience is not the only or the be-all, end-all. I welcome other comments and questions so that we get a good variety of experiences from others that have worked in different settings as well. I'll start with some of the things that we've learned after implementing SBIRT, particularly in medical settings. And I've listed there some of the projects that I've been involved in or are currently involved in. And some of the things that obviously come up in medical settings, it's usually a very fast-paced environment. A lot of appointments happen in the course of the day. Panel sizes are very large. You know, a physician might have 2,000 patients on their panel. And so with that, who becomes the champions when you want to implement SBIRT in a medical setting? Now, clearly, the primary care providers, we want them to be on board. They tend to often be the leader of a team if it's more of a team-based environment. They may or may not do all of SBIRT, but it's useful for them to be engaged in the process and aware of the process so they can also help support it. The other, I think, often underestimated champion in SBIRT in a medical setting is the clinic manager. This is often the person that is working behind the scenes and is involved in many aspects of the business of healthcare. They know what's happening in the billing department. They're overseeing perhaps the nursing staff. They're working with primary care physicians. They see things from both an operational and a clinical side. And so we found a lot of success when implementing this when clinic managers are involved from the ground up in building an SBIRT project. As far as the connection to substance use, I think a good way to engage staff in conversations around why SBIRT would be to connect it to the top medical conditions that are being treated. And we know that there's, a lot of research around the connection between diabetes and substance use, or heart disease, or, treatment effectiveness and medication adherence, or dosage of medication. And so that has been a nice starting point if having conversations to say, why should we be involved in that, and why would SBIRT be something worth us doing? The last piece of this is that some of the meaningful data that I've seen being tracked in medical settings, of course, we've got all of our standardized SBIRT data around number of screenings and brief interventions and referrals to treatment. Additionally, I've seen good conversations happening around, whether the use of SBIRT is helping to improve other medical conditions. The person has now maybe reduced their use, and we're starting to see that they're better able to manage their diabetes, for example. Or is a reduction in use starting to connect with a reduction in ED use, or less accidents or injuries as a result of implementing SBIRT? It's an interesting process to see clinics start to see their wheels turning to say, wow, I see now that there is a connection to these things, and substance use isn't just something to be done, by another type of specialist. One other thing I want to have us think about in this reign is that, we do certainly know every fall that, the flu shot, the promotion of did you get your flu shot is something that is a common thing. It's also very routine to have our blood pressure taken when we go to the doctor. And we obviously know how important it is for early detection of cancer. And so we do a pretty good job of screening and doing interventions and even referrals to treatment when needed for some of these things. And so in the medical context, another way to think about the work of SBIRT is to look at what's been done from the U.S. Preventive Services Task Force. This is a group that very rigorously reviews the research around a number of, much more than just this list, a number of different preventive services. And they then go and grade it on level of evidence supporting whether that preventive service should be done. From there, there's this study that came out where they really worked to look at a couple additional things: the cost effectiveness of delivering that service and the clinically preventable burden of disease, of injury, premature death, if that service was delivered to all people in a target population. And interestingly, alcohol screening and brief intervention for adults is a very highly ranked service. So it's another way to have a good conversation with primary care providers and other staff around the importance of identifying and making sure that alcohol is a topic that's addressed in the primary care setting. It's interesting to see that it's ranked as high as colorectal cancer screening. That's another one that we definitely see a lot of marketing and promotion around the importance of that. And it's ranked even higher than blood pressure screening, which is a very routine part of practice. I know anytime I go to my doctor's office, I know my blood pressure is going to be taken. So it's another opportunity to have a good conversation around, would it be worth our time to do this? Is it a priority? And how do we juggle it among all of the other priorities that come up in primary care? The other thing I want to share about primary care is thinking about workforce and workflow. This has been pretty much the most common workflow that I've seen done in primary care. Of course, there's variations, but most often what happens is that the front desk person is handing out or giving a brief screening. So there's full screens and there's brief screens, but a brief screening either on paper or on a tablet or a computer of some kind in the waiting room or when the person is at least checking in. And then most often that is then brought to the rooming nurse or the next person. It might be a case manager, care manager, who's going to review those results and, if warranted, offer a full screen. And the reason I see that most common is because in primary care, the goal is really to cast a wide net. And so a brief screen with 1 or 2, 3 initial questions gives them a chance to see, is this someone that has potential risk for substance misuse? And then in that second phase, they will do a full screen. Then very commonly, the primary care provider comes in the room and does what they would be doing. And in addition, with SBIRT, they're aware of the screening results and can provide some education or have a brief collaborative conversation around use, perhaps connecting it to the medical concern that they're there for, or medications or other areas of treatment. And then if a clinic has this other role, that is sometimes where there will be a warm handoff to a behavioral health consultant, a care manager, a health educator, a person that can do a more thorough but still brief intervention and talk with the person further about reducing their use, being aware of their risk. Now, also I've seen sometimes where you get some real savvy care managers who also are very aware of the importance of timing and workflow. And in a, again, busy primary care office, if the primary care provider has gotten behind, or they've had so many patients with a lot of complex issues that they aren't able to stay on track, then sometimes that care manager will hop into the room before the primary care provider comes in and has a conversation about the screening results. Now, it's real important not to slow down the doctor or to interrupt the flow. So that's a piece of working out a workflow so that everybody is supporting this work, that SBIRT is seen as a valuable model, and that everybody is supporting all of the goals that the person is coming in for. Another piece to think about with these, some considerations, is that in the medical side, everybody working at the top of their license, quote unquote, meaning that it does take a team to support behavior change, and adding things like SBIRT or other additional screenings does mean that everybody has to take a minute to say, well, who's going to do this work? Do we have the ability to do this well? And the role of a care manager or a health educator or a behavioral health provider in primary care can be a nice way to make this really work well, because they can be given, if they don't already have good training around how to elicit a patient's reasons or ability to make a change. And often the primary care provider doesn't have enough time to do that in full. So having this extra person or additional person, or thinking through who do we have on staff and how do we use people at the top of their license so that we're providing good team-based care. To that end too, the front desk person, I've seen where front desk staff often are really happy to be able to participate in this as well, and handing out the screening initially, having some real simple basic messaging to explain why these questions are being asked. Fitting them into the context of other screening questions is an important piece. And then, of course, having good coordination with a referral for treatment if it's needed, because often specialty treatment for substance use disorder is not on site. Sometimes it is, which is wonderful. And if it's not, having good, tight coordination for that, which often becomes the role of that care manager. So now I'll say a few things about what we learned about using SBIRT in the court system. I was part of the project that I named at the bottom that was in the 6th District Court in northern Minnesota. And what we learned about the culture of working in this world was that, the process can be very lengthy. Sometimes it can take weeks or months to get a person's court date. And there's a lot of anxiety often around that time. A lot of paperwork, a lot of delays, things can happen. It's also obviously a more mandated environment, and as we talked about the word patient, the word offender is part of that vernacular. And so when we did this project, what we learned was that some of the key champions were the Department of Transportation and Public Safety. The judge in this case, similar to a primary care provider, was really the lead of the team and someone that we really needed on board that would buy in to this project and see this as a valuable model. Also, other community stakeholders could be sheriff, public health providers, because really SBIRT is a public health approach. And so we found bringing all of these people together and more were really important to make this work. Some of the connections to be made when it comes to thinking about substance use is this impacting the number of arrests and incarcerations? There are fees associated with getting a DWI and penalties and such. And then the meaningful data, as in primary care, we were talking about health-related outcomes. Here we were talking about reducing recidivism. And that was a real importance to this group, that they wanted to see if they could measure the recidivism as a result of doing SBIRT. And it was really an interesting process to take this into the court system, to be thinking about, if the timeline is really lengthy, could there be, and in the case of the project I worked on, they offered an incentive to those that received SBIRT services that they were able to move faster through this system. So they were able, within 1 or 2 weeks, to get their court date. So that allowed them to kind of get it over with, as we heard from a lot of people. And it seemed like a nice sweet spot. It wasn't too soon, but still soon enough that it became a teachable moment or an opportunistic moment to have a good conversation about the use of substances and the resulting consequences. When it comes to workforce and workflow, so we tried a few different things in this case. The first thing I would say is that some of the lessons were similar to what we found in healthcare settings. Where does the individual go for SBIRT? What is the paper trail? What is the physical environment? And where are different team members physically located so it doesn't disrupt other services or other parts of the process? So in particular, what we first did is when the person had their court date, which again was moved up, so it only happened, it was within 1 or 2 weeks. What happened next was we first tried on the left-hand side here that we would have that person report to probation. And probation was the place in which the person received the screening and the brief intervention. From there, they went to the courtroom for their arraignment, and the judge reinforced SBIRT as a program that we wanted the person to participate in and be followed up with. And then probation followed up with that person at 3 months to find out what kind of changes they've made, and obviously to get toward that recidivism goal. So we tried that, and there were some pros and cons to that. One of the pros was that having probation really involved was useful because they were already in the court building. They had an office, and they were part of the system. So tracking people that received SBIRT, the paperwork trail, the paper trail could pretty smoothly make its way through the system as well. Now, what we also found, though, is that there was also an opportunity to try another route. And the reason being is that if the person had their court date and reported to probation first, there were sometimes some timing issues where the person either didn't, they got lost on the way to the probation office because they had on their mind that they were here to see the judge. So they were very nervous, and when they did get to probation, their mindset wasn't on talking about their use of substances and a good brief intervention. It just wasn't, the timing wasn't quite right for that. Also, we had some people that skipped out on the SBIRT part of it because they were so focused on getting in front of the judge that they just bypassed the first step, which was going to probation's office. We also had people that were running late, and so by the time they got there, they had to go right to their arraignment. And as we know too, sometimes the judge's schedule was unpredictable, so either they were delayed or they were ready and the person was still back in probation. So really interesting to try this in a way and see what was going to work and not work. And then The second, the other workflow there is the other way we chose to do it, which was the person came in for their court date, went right to the courtroom for their arraignment. That's what was on their mind. That's where they needed to be to not interrupt the judge's flow, right? So then the judge was able to introduce SBIRT and be the first person to mention it, which is very powerful, similar to what we sometimes talk about with the influence or the white coat effect of having a primary care provider talking about substance use or behavior change. In this way, the judge could introduce it and say, hey, it's really important that you are part of this process, and then they could basically introduce the person to seeing what we called an interventionist. In our case, it was a treatment provider who came on site from a local chemical dependency treatment center, came on site and was able to do SBIRT in a very nearby room right outside the courtroom. That way, the person also didn't get lost, didn't have to go upstairs or downstairs or to some other location. Some of the pros of having this person doing SBIRT was that they had a lot of experience and training. They knew they had to do a very therapeutic approach. The brief intervention came pretty naturally. Some of the things that made it harder, though, was that they weren't part of the court system. So there wasn't a natural space. We had to find a space for them to do this work. They didn't have their own office. And they also didn't have access to the system records. We had to think through how will they maintain their tracking, how will that be coordinated with the records that are done in the courtroom. So really interesting to do this in this setting. And some of the other considerations was what other people or roles could people play in doing SBIRT. As I said earlier, we had public health support. So could a public health nurse come on site and do SBIRT instead of a treatment provider? What is the role of coordinating with treatment for someone that might need it? Where is the right timing for this to be the right teachable moment, where someone isn't so nervous or scared or intimidated that they're just telling us what we want to hear, and feeling that this is a genuine opportunity to learn some things. And as the judge often said, that he wanted to know that we had the opportunity to do a lighter touch for people that needed that. And this project was all around first-time DWI, so his goal was to say, not everybody needs a heavy hand, and so how can we use SBIRT to identify those different levels of risk? One of the other primary settings that we have implemented SBIRT at the National Council is in mental health. And Tracy introduced me with this initiative that you see at the bottom here that the Hilton Foundation supported, where we had many mental health providers saying, we really want to do a better job of identifying substance use risk. And so some of the work that we learned there, first of all, there's an assumption that people that have a mental health background also have a background in substance abuse, and that it's really basically the same expertise. Now, there are some things I think that complement one and the other. And we had a lot of mental health providers saying, this isn't an area of expertise for me. I maybe had a few additional classes on this when I was in school, but it is a different thing that I just don't know that I have the expertise. They also said that, staying brief was a challenge. That brief intervention, they're used to maybe a 50-minute therapy session or 30, 45 minutes. So doing this in a very brief, time-sensitive way was new. And as we know from the vernacular in behavioral health, people are referred to as a client or often a consumer. Some of the main champions, if you're looking to implement this in a mental health setting, an executive director is key. We've got to have leadership support. They've got to be able to say, yes, this is something that connects with our mission and our vision as an organization, and it's something that will help keep us viable in the long run. Program directors, clinical directors are also important staff. The connection on the substance use side for a mental health setting, we've seen often that they're saying, we want to have those co-occurring capabilities, and we want a better relationship with those that we are referring people to. Yes, we refer a lot of people to a treatment center or treatment services, and we want to tighten that referral and that relationship because so many people are seen for both. Some of the meaningful data that we were able to rally these stakeholders around really came back to the social determinants of health, wanting to improve mental health conditions, depression, anxiety, but also helping people with their employment, getting stable housing, improving relationships. So a lot of buy-in came from having these kinds of conversations of how substance use fits into these other metrics or these other meaningful goals. A few additional things to think about with why screen in this setting that, as I mentioned, that people with mental health are disproportionately affected by substance use. It's a very common co-occurring issue for a lot of people. And boy, mental health practitioners are really, really a good fit in a lot of cases to do this screening and brief intervention, because a lot of the brief intervention is based on some of those therapeutic skills, on skills in motivational interviewing, on connecting with the person to help them reduce their use and improve their life. So a lot of things happening on this slide. I'll start with the one on the very far left. So we found that with groups that said, when we have a brand new person that comes in, our intake process is pretty lengthy. In mental health, in a lot of cases, the intake is an hour to 2 hours long because there are so many things that we do ask, that we need to ask, or that we feel we need to ask. So when a group says we're going to take this on, in the case of a new intake, what some groups have learned to do that has worked for them is that the primary clinician, not necessarily the intake specialist, if that is a separate role, but the primary clinician adds substance use screening sometime in that first 30-day assessment period. Now that won't work in all mental health settings, but it was a learning in several that they said there's so much to do in that 1 to 2 hour primary intake that they turned it to the primary clinician to ask those questions as they got to know the person and they came in those first 30 days. Connected to that then is the rescreen or that follow-up process. Some primary clinicians would add for themselves a reminder in their email calendar so that they would, at a 90-day point, remember to rescreen the person. Now, there's a lot of things that go in between those two boxes, but that's just one way of looking at how that's happening. We also found, too, that a lot of mental health clinicians and organizations took a good look at what their intake screening questions were. They weren't always validated and evidence-based questions. They might have been just one question on history of substance use disorder. And SBIRT really got them thinking about levels of risk and other questions that are validated that can maybe even be replacing some of the other intake forms to make this a better process. So that's the one on the far left. Now the one in the middle is another way of looking at this, where some groups have said, we're going to email some of these key, what would otherwise take a long time in the clinic, paperwork, either email or mail, or have the person fill out prior to that first visit. And then the counselor or the therapist reviews it with the client when they do come in. With that, if there's a need for a referral to treatment, we've seen a really nice model where the counselor continues to monitor progress, right? And that's so important if someone is referred for treatment, that they still have a relationship with, and there's accountability from the mental health center to check in, make sure that they're continuing to receive services for substances, and that becomes part of the therapy. So if they're still coming in for therapy, having a conversation about how is it going on the treatment side, so that it's a much tighter process and everybody's feeling accountable for that. On the far right side then, another way of doing this work in mental health has been that if there is an intake coordinator separate from a therapist, that they have done the initial screening, either on paper or verbal, although we do see a lot more accurate answers when the questions are not asked verbally, but they are part of a paper or electronic. And then what is sometimes happening is that the brief intervention is done by the therapist. The intake coordinator's job is just to do the intake, and the therapist is doing the brief intervention. That can sometimes break down if there isn't a good warm handoff or there isn't trust established. So it's been really important for the therapists that pick up the brief intervention that they're able to make that as seamless as possible. Sometimes the therapist is the one that does the full screen so that they're already having more of a conversation about use. And then in that case, sometimes the rescreen is done by that intake coordinator, especially if they're not getting services any longer. And these things can work if there's good warm handoffs and there's good trust built. If the therapist says, you know, we're going to have someone call you in 90 days, in 3 months to see how you're doing, and that's known then when that intake coordinator calls, why they're calling and who they are. So some considerations on the mental health side. As I mentioned, sometimes that intake process is already pretty long. So how do we add these questions to it or make it more effective by doing it at a different time or replacing other questions that aren't validated? How to integrate brief intervention if it's being done in the context of therapy. Groups have had to think that through because if they're able to bill for SBIRT or the brief intervention, sometimes they have to delineate that in their notes so that it's, you know, there's the 15 minutes or whatever it is with the billing and how to document that separately from therapy happening. And then I really like to point out that the term harm reduction really resonates in mental health settings if we talk about SBIRT in the same way, that it might be reducing a person's use is progress and is a goal that's worth striving for. And that's very common in mental health settings to be thinking about harm reduction. And if we can do that in the context of substance use and that it's not an all or nothing, they have to completely stop using, and working that out in a therapeutic way, I've seen a lot of engagement and excitement from behavioral health and mental health providers to say, oh, I can do this work because I really understand harm reduction. And then I just added a quote here that I thought was pretty powerful from one of our mental health centers, that they saw a cognitive shift in their staff. Their staff really bought into and were more consistently doing screening and brief intervention. They were initially not certain that they could do this. They didn't know that they had the competence, but with good training and with thinking about what their mental health skills already brought to the table, they saw a really strong improvement in screening and brief intervention. And I wanted to make sure to touch on the topic of adolescence because that involves some unique aspects as well. So when we worked with adolescents, SBIRT, confidentiality is so important. And we saw many, many times that the providers in the room when we were doing SBIRT implementation didn't all have a consistent way of talking about confidentiality. So if you're looking to do this with adolescents, review what your current confidentiality policies are, talk to staff about how they explain what is the limits of confidentiality, and make sure everybody's really on the same page, because that was a bit of a surprise to us that while a lot of people would say, oh yeah, we talk about that, and then we would say, well, what is it that you actually say? There were some differences in what people said, even within the same organization. And then as we know, with working with teenagers, you know, rapport and engagement is important, and it's sometimes hard to gain. And so what is the right timing of doing the screening? Is the person put off by it? Are they wondering what the confidentiality policy is? Do you tell them but ask them to do a teach back so that you're on the same page about what that means? That can go a long way in being able to talk about and introduce reducing or their use of substances if you haven't really engaged with them or developed a rapport. A few comments on school-based services. We saw some advantages to doing this in the school because there's more opportunity to follow up because the kids would come into school so they could easily track them down, have routine appointments or visits. Obviously some differences in whether it's a school-based clinic versus the school system delivering SBIRT, you know, regulatory differences, who has access to the health records, who has access to the school records, and then what are the staff delivering SBIRT? Is it a health provider? Is it a education provider? And I just wanted to make a point of this last bullet here that there's been some new legislation in Massachusetts. New Jersey's looking at it as well. In Massachusetts, about a year ago, March 2016, they passed a House bill that now requires public schools to do SBIRT in the schools in 2 grade levels. And I think it was 7th and 10th grade. So there's some really interesting work going on in Massachusetts to train school providers in doing SBIRT routinely in the school system, and New Jersey is following that and watching that, and that's some legislation that's been proposed there as well as of 2017. The last thing I'll mention about SBIRT in the schools is that, first of all, we've seen that if therapists are already in the schools, this can be a really nice thing to add if we're mindful about working with them to say, how does this enhance what they're already doing? So that it doesn't feel like one more thing. That's actually pretty universal in a lot of settings. How does this build with the capabilities that the system already has? And it feels very fluid and easy to take on, relatively easy, because it's somehow a part of what's already happening. And then the other point here about traditional model versus the SBIRT model. So, you know, the traditional model in schools and in a lot of settings is that if there's been a problem, that's how we identify that someone might have a substance use problem. You know, with kids, if they get in trouble or they skipping school a lot. And the SBIRT model is doing much more systematic screening so that, you know, we're casting, again, a wider net. And I think it really speaks volumes that a good screening in SBIRT is doing that. It's not just picking out certain kids or certain people. It's saying that, you know, we could have a lot of different kids and we want to detect any of those unmet needs, whether it be a quote-unquote good kid, right, an athlete or an honor roll kid, that it moves away from that and saying, you know, everybody is going to be asked about their substance use so that we're meeting the needs that we might not otherwise be finding. And school-based health centers are a huge part. I think we underestimate how much that is a service that's used by a lot of people. And so how can we do more in a school-based setting to make SBIRT routine? The other thing I just wanted to mention here is that I don't have specific slides on these other settings, but I wanted to give you resources if you are interested in some things about HIV and AIDS treatment centers, emergency departments, and trauma centers. There's some really good resources available to you if that's your setting or you're looking to work with people in that setting and how you might be able to do that. Okay, so now I want to talk about some common threads and some lessons learned. And one of the big ones for us, and I mentioned champions before, but what is the role of champions and supervisors, particularly around connecting data to actions, and I would add establishing policies and procedures that support ongoing SBIRT. So in one of our projects, what we did is we looked at some of the data and we did some teaching around how to use the data to have conversations. So it isn't just there's somebody looking at data and they're over in that department, but we're all looking at the data. So how can the champions and the supervisors use data to have conversations about how the substance use SBIRT project is going? This is an example of you know, some of the groups we worked with that were initially discouraged because they thought their enrollment, as we called it at the time, or the use of SBIRT felt very low. And instead, we turned that around and said, you know, let's see the good in this. So first of all, this is great. There is an increase. And so really coaching supervisors and others to say, is it moving in the right direction? Maybe it isn't the ultimate numbers we want to see, but is it going in the direction that we want to see it go? And then what factors contribute to this increase in use of SBIRT? So rather than focusing on the 0 or the 31 to 34 wasn't a very big bump, we really focused on, okay, but we did get it to 52 people that had participated in SBIRT. So what contributed to that? Was there more people trained in using this? Were there signs hung up that said, we ask everyone about substances? Was there additional primary care provider support, if that was our champion? Was it that we now are tracking more accurately than when we started? And then really nice to complement that with finding out which staff were part of this increase. So breaking down the 52 or the 31 people that received SBIRT to say, whose caseload are those individuals on? Or who were the staff that did the screening for those particular people? Because they become another round of champions and people we can learn from to say, how is this workflow we devised happening? And is it efficient? So that's one way in which we talked about data. Another way, regardless of setting, is looking at then the interventions. And so now specific to SBIRT data, we looked at in this project, we looked at people that didn't receive either a brief intervention or a referral to treatment, those that received only a brief intervention, those that received both, and those that only received a referral to treatment. And we were actually highlighting what was a positive here, that no one received only a referral. We were really trying to emphasize that it isn't S to RT, it's S to BI to RT, and that brief intervention is the glue that connects the screening results with an awareness of use, and then if needed, an RT. So we really decided we were going to emphasize that. And then we wanted to talk about who were the clients that didn't receive the brief intervention or the RT when it was indicated, because we want to manage that appropriately. And as you can see, our numbers were in the single digits. And what we said was that's actually a good opportunity. If your numbers are 100, 200, 500, it's really hard to look back and say, who were those 500 people? So if your numbers are in the single digits, you can look back and say, okay, who were those 8 people? Or who were those 5 people? And what can we learn from these early days of implementing an SBIRT program? And then one more example, and this was with adolescents, because our teams were using the craft, and in one case they were using another tool called the Uncope. Again, we capitalized and we addressed the positive first. So, hey, we've had 7 people with a documented improvement. Their craft score improved or was reduced. And so we really wanted to celebrate that and to really talk about that 7 people's lives that were influenced because of implementing this model, making them more aware of their use. And then what can we learn from the staff who participated in that? What were those conversations like? What were the circumstances for that person in their initial craft score and in their follow-up craft? What other things perhaps were going well in their lives, or were they finding we're more on track? And then, you know, as you collect data, always be thinking about where can you promote that data and demonstrate your value, because people are looking at this. Funders and payers and other stakeholders are wondering and wanting to know, is that clinic providing value in their community? Is our clinic continuing to live and deliver on our mission and vision? And tying that back to data ties it back to actions, and I think helps staff feel accountable and responsible and proud of the work they're doing when we can show it in these kinds of ways. Another way to think about when you start implementing this, regardless of setting, is what is your baseline? And start collecting data, and then what are your benchmarks? So this was an example. We had a group that said, you know, we look back and in 2015, we only were screening about 20% of the people that came in the door. And our goal then in 2017 is to get that number up to 80%. And putting a line in the sand, even if it's somewhat arbitrary, is really a nice way to help everybody have some clarity around why are we doing this work and what are we hoping to accomplish. And so leaders and other champions can really rally staff and others to say, here's what we're seeking to do, and these are the reasons why. So the other piece that I think is really important, along with data for champions and others, is to establish policies and procedures. When there is a policy or an SBIRT procedure that's written, that's in place, it really says this is a standard part of our work. This is something that isn't just something we're trying for a little while. It shows we're serious. It shows that we are holding ourselves accountable to continuing to do this work. It also decreases confusion. You know, hopefully a good policy and procedure, while it's meant to be a living document that is updated, it's also meant to outlive staff when there are turnover. Or if you're lucky enough to have a staff person that won the lottery, you know, who is going to continue and carry on SBIRT? If all of that information lives in just a few people's heads or in a few people's own notes, then it isn't sustainable. So regardless of setting, having a policy established for what are the roles and responsibilities of people that are responsible for doing SBIRT. And maybe that isn't all of the staff, or if there are key pieces of SBIRT that are meant to be done by certain staff and those roles, having that really defined. What is the ongoing training and supervision for staff that are doing SBIRT? This is one that, you know, in mental health settings, there's sometimes a lot of turnover. There isn't a lot of settings regardless of that. But what is the ongoing training plan? If you had a trainer come out and teach people, and then all of those people are no longer at the organization, who's going to teach the next set of people? So having an ongoing training plan, having a training manual or process for retraining, either new staff or staff that maybe learned it initially, haven't done a lot with it, and you're wanting to pick that back up. What's the retraining? And then how do we supervise, and what's the expectation of the supervisor to make sure that there's good fidelity to that model? We know that brief interventions take practice, and there's different ways to do them. So what is the ideal way based on your population, and how do we know that good quality brief interventions are being done? As you saw from a lot of my previous slides, there's a lot of different ways to do a workflow. And everybody has to kind of figure out, you know, what is the right one for us, and how do we need to adapt that as time goes by. If we now are hiring a behavioral health consultant in our primary care clinic, we might have to change our workflow. Or if we now are adding different screenings or additional screenings to our process, is that the same workflow, or is there some differences? As far as some of the next few bullets, so using SBIRT tools, you know, what is going to be our standardized screening? As new research comes out and new tools are developed and validated, at what point do we reevaluate whether a different tool would suit our population better? What is our process for doing a referral? Do we have on-site substance use treatment services? Do we have a new service provider in town that we want to get to know and be able to refer to them? An interesting one on follow-up is we had some groups saying, you know, we standardly follow up with all of our clients, this is a mental health setting, at 6 months because we have to review their treatment plan with them at 6 months. So they built in their SBIRT follow-up to happen at the same time. So staff didn't have to think about that happening at a different time. It just made it more consistent. Another thing to have a policy and procedure around is documentation. Where in our electronic record are we documenting that the screening was done? If we change EHR vendors, now where do we document? What needs to be documented to show that a brief intervention was done? And then all of this gets to, you know, quality improvement, because what we're ultimately trying to do is be both efficient and effective. And ongoing and frequent review of data informs our staff, informs our policies and procedures. I wanted to add this resource as one that you may find useful. What this is information that came out of SAMHSA's 5 years of implementation. They have been providing SBIRT grants for the last 5 years, and they've had 29 states doing SBIRT, 2 tribal councils, and 1 U.S. territory. And from that, there's been 2 million, actually more than 2 million screens. SBIRT screens have been done. So they have a number of papers that they've published just in the last several months. And this one in particular is around sustainability. So there's other papers on, brief intervention and brief treatment, the staff that could be doing this work, cost effectiveness, but in particular around sustainability. I thought this was relevant to us today, that they talked to about champions. And they said champions help with sustainability when their role is to facilitate relationships, whether that be with treatment providers, whether that be with in-house with staff delivering the screening versus the brief intervention. Champions need to continually keep this on the forefront through presentations, through workshops, through retraining or coordinating or making sure training is happening. They can also be instrumental in securing funds, whether that be grants or looking to see if the SBIRT codes are available in the state you live in. And they have to have dedicated time to continually doing this. So often when people start implementing SBIRT, they name a program lead or a project lead, but then that person, after SBIRT has been started, that person takes on another project or moves it back into other work they were doing. And this is saying that that person or someone needs to continue to have dedicated time to looking back on the data, to be looking at workflows, reviewing policies and procedures. Secondly, one of the sustainability factors was staff, and whether it be in-house specialists versus external people that come in. They found that in-house staff that, and when they say specialists, they mean people that have had training in SBIRT and that they have dedicated time as well, so that SBIRT doesn't fade away. And that this could be integrated with other screenings, other services, so you're capitalizing on what you're already doing and doing well. And then I think this third one's really interesting as well, that over the course of these years of these organizations implementing SBIRT, a big majority of them, 67%, found that they adapted from where they started because of relationships changing with different partners. A different community partner came on the scene, or they had staff changes or turnover, or they were maybe using grant funding to get this started up and they're now reallocating. So do expect that the way you start doing SBIRT may not be the way that SBIRT ends up for you. And I think that's not a surprise, really, if you think about how quickly healthcare is changing, or even in the court system. When we worked with them, they saw changes as well. So be ready to adapt and be ready to be flexible as time goes on and be ready to review policies and procedures. So why we've seen that SBIRT does stick, or what are the factors? Regardless of setting, we have found that if you can show that it improves clinical care, that you make it a systematic, reliable, consistent process that is person-centered, that it can be impactful even though it's brief, when it improves clinical care, SBIRT is likely to stick. Related to that, when it can transform your culture beyond just being this model we do over here separate for substance use, that it includes substance use and it becomes a way of working, that whether we then move on to screening for depression or anxiety, or whether it means we take a harder look at our intake process, or we look at the way in which we utilize different staff expertise. All of those things are pieces that can transform culture that sometimes, very often, start with an SBIRT project. Preparing organization and workforce for healthcare changes. We're increasingly becoming accountable for outcomes and for doing measurement-based care. And SBIRT is another way of getting a lot of people started in thinking about measurement-based care. New audiences, integrated services are becoming more and more the way in which we work, which actually gets to that last bullet too, that substance use is a chronic health condition, and healthcare is more than just mental health or substance use. It's all of these things, and so that introduces any of the stakeholders that might be doing this work to potentially new audiences to be able to promote the work that they do. One of the last slides I want to end on is this idea of a real common thread we saw was this quote, SBIRT encouraged programmatic changes center-wide. And in doing SBIRT, it prompted this group to say, we decided to review all of our practices for screening, and now we're really being solid about proper screening happening in multiple areas within their organization with adult and adolescent population. So they didn't start with that, but that is what evolved as a result of doing this work, that it really prompted them to take a good look at this different work, that it can tighten up efficiencies, that it got them looking at their forms and their tools, removing extraneous questions that they maybe thought were required, and it turns out they weren't required, or they weren't as important or useful as they had initially thought. Workflows became smoother. We had some groups that said this really reduced our wait times because we now are thinking through the flow for the patients or the flow for the paperwork, and really making that a tighter process. Maximizing staff expertise. We've seen where staff are really happy that they are part of this work, that it can enhance their role if they have good training and supervision. They feel more coordinated. They feel like they aren't tripping over each other or being redundant with asking patients about their use or assuming a different provider was asking, that it's much more streamlined. Also, I found that no matter where you are geographically or what type of setting you're in, these are some of the key questions to be thinking about. The first one, again, I'm all about being strengths-based. So the first one says, what challenges does SBIRT have the potential to solve for us? Rather than, SBIRT's going to be one more thing we have to do. Really saying, what is it, where are the benefits, and what could it potentially help us with? The second one about capitalizing on existing opportunities. So we had a lot of primary care offices that had already done depression screening and management. So they said, we now want to add substance use because that seems like a natural next step. Or we've seen people start with substance use and add other screening. We saw in the court system that they wanted to be part of a conversation about change, not just being a punitive group for the people that came into the court system. They wanted to know that they could have meaningful conversations to help people improve their lives. Knowing who your champions are, having a continuum of use, as far as that one goes, you know, not just seeing this as there are people that abuse substances and people that are healthy, and knowing that we've got people that fall in a lot of places in between that, and having champions that can really talk that through. Thinking about where SBIRT fits in, how it will be funded, whether you have foundations or grants or have SBIRT codes that are available, having data so that you know whether it's working or not. And then as far as sustainability, and I think that's where community partners can really rally around this. You know, if we're going to see substance use as a public health issue, that means we want the schools involved in conversations on this. Could there be media campaigns that support that we're doing this work? I mentioned on one of those first slides, Chamber of Commerce, law enforcement, social services. If we think about this rather than just that's something that the doc needs to do, or that's something that mental health handles, and seeing it as a public health opportunity to influence behavior and influence health and all things in between, we can involve a lot more stakeholders. And then I wanted to just share this, that I recently did a SWOT analysis with a state that was really looking hard at their SBIRT capabilities and opportunities. And so we did a SWOT analysis in the state where these were the kinds of questions I asked this group of stakeholders, and I just wanted to share it. So if you wanted to take it back and think about it in this way too, that what are the strengths that already exist here that might be lacking in some of those other lessons that Pam shared, or vice versa, that, wow, there's some really great things happening in some of these other contexts. So how could we leverage those and make those strengths in our organization, and weaknesses that either we have or that we saw in some of these that we could potentially fill, opportunities that SBIRT provides for us, and then knowing what the threats are. What could make SBIRT a challenge for us in the realm of sustainability or implementation, so that we're aware of those up front and can work toward those all throughout. The very last thing I want to share before we take questions and comments is that we at the National Council have an opportunity specifically for federally qualified health centers, that our newest project has been around creating an adolescent SBIRT change package. So this is a tool, a document that was developed by many experts in the SBIRT field. We've been so lucky to bring together researchers and trainers from Harvard and UCLA, the Kaiser system, people that have been implementing SBIRT, the Hilton Foundation's involved in supporting this. And they came together and we've really wrestled with what are the key elements that are necessary for implementing SBIRT successfully for adolescents in federally qualified health centers. So we're looking for FQHCs that want to take this change package and implement it. And you would receive support and technical assistance from the National Council. And we ask that you have a behavioral health provider that you would name as your a partner in this, so we can think about the connections that need to be made with behavioral health. And we're excited to say that we want to work with you. And so there's a request for application that is due pretty soon already, May 9th. So I named my colleague here, Charday, who, if you are interested in getting that RFA and providing it back to us by May 9th, we would love to be able to work with you. With that, I will stop talking and look forward to hearing comments, your experiences in these settings or others, and questions as well.
Thank you, Pam. That was terrific. Thank you so much. It gave me a lot to think about. I'm sure it gave the folks who are joining us today a lot to think about. So thank you so much. There was a lot in there for us to be thinking about. We do have some questions, and I will just remind folks that if you haven't entered your question already, you can use the questions pane. Go ahead and type your question in there, or your comment, and I will start with, well, one of them came in before you answered the question. You were talking about the role of champions and providing some pretty specific key elements, the role that champions play in settings. So I think you may have answered that one, but Antonio, if you have a follow-up question, go ahead and type that in if you'd like some more specifics. But clearly, you anticipated some of the questions coming, Pam. Let's see what other questions we have. Yes. So I think we have a couple like that. Charles is agreeing and says harm reduction really works, and is a proponent of that. You mentioned that earlier. And I think we share that. Sometimes that phrase or that approach or that thinking is more appealing or more accepted in some settings than others. And so that can be common in some and a difference in others.
Right.
Let's see.
I'll just jump in about the champions. I think something I didn't say, but it's worth thinking about, is sometimes the champions aren't necessarily the ones with already the most experience in SBIRT or whatever you're trying to champion, but it's the people that are most eager or interested in trying it, right? So we've got, natural early adopters in some cases, or people that say, I've always been wondering if I could do more with my clients or with my patients, or, I'm curious about data. I would love to think more about how we could use our data. Those are champions too. So we can teach them how to do this, and yet if they've got the eagerness and potentially, hopefully, some capacity those are also natural champions that we can engage.
Yeah, thank you. Yes, it's Antonio replied and said, yes, thank you. That's appreciate your answer. It really is enjoying your presentation, and said he has no follow-up questions. So thanks for expanding on that.
Good.
Okay, let's see some other questions here. Could the speaker touch on recommendations related to brief screening completed on paper versus being done in a conversation with a medical assistant during rooming?
Oh, yeah, that's a great one. So, the research is showing that, particularly with adolescents, but really with adults as well, not asking the questions face-to-face or verbal tend to give more accurate, and I won't say honest because I think that isn't very patient-centered, but more accurate responses. Unfortunately, we still have a stigma, and we still have some awkwardness or uncomfortableness about asking questions about substance use. And so having them on paper tends to, for one, we can trust that it's reliably delivered because it isn't the medical assistant or whomever it is asking the question and then maybe asking with additional words. So it's there, it's on paper, and the person can fill it out as they would. It's not to say we can't do verbal, and I think we have to think about culture. We have some ethnic cultures that oratory is much more favored, and so if we want to do that, sometimes that is going to be just as effective. But it also comes down to the comfort of the person asking the questions, and if they can make this very fluid and very conversational. And there's lots of different ways to do that, to say, to think about the spectrum of use and to say, some people use substances and, anywhere from 1 drink to 10 drinks, or however you would want to language that, so that the person coming in knows that we want to hear, for you, what is accurate. Also delivering the message by saying, we want to know about anything you put into your body, whether it be medications or substances or caffeine, or, all of those things, to also help normalize the conversation. So it isn't just, I'm asking because there's a good and a bad answer. But overall, if those questions can be handed to the person, it just takes out that interpretation, which sometimes creates less accurate information.
Thank you. Thank you for the answer to that. There's another question that about the screening tool itself. I'm wondering if, thinking about commonalities and differences, does a particular screening tool or a couple of different screening tools rise to the top of those you've seen most common across settings?
Yeah, so first of all, for populations, for adolescents, the CRAFT tool is pretty popular, and regardless of setting, I've seen that really get a lot of mileage. Also, the S2BI, people are familiar with that one. That one's gaining in popularity as well. It's a very nice and simple tool. It's asking about really the top 3 substances that in research we found if adolescents are using tobacco, alcohol, or marijuana, those are the 3 to prioritize asking about. And then if they are using those, asking about other substances. And then the CRAFT tool, what is nice about that one is it asks, the C is about riding in a car with someone who has used. And so that can get at, even if the adolescent says they're not using, is a friend using or a family member, and then that's a risk as well. So that would be adolescents. For adults, I mostly see people using the audit and the DAST. Audit is alcohol, DAST is for drugs, or the assist. The assist tool adds in tobacco. And really, regardless of setting, I've seen it's more about if the group wants to also do systematic tobacco screening, then they hold on to the assist. And if they still just want a brief tool, which most people just want something quick, The audit is very appealing because it's just 10 questions, and the DAS similarly has a short number of questions. Those are, for me, the ones that rise to the top. There are others, and I've seen also a lot of groups will say, well, we're regulated that we have to use this tool. And before you move into using that tool, I would say double check, because we've had people say, oh, I think we're required to use this, and then I really push them to go back and make sure they're required, and it turns out they're not. Or the person, or the body that required it is willing to look at another tool. That happened in the court system, where they completely changed and they're using the audit in this particular system, and they are thrilled because it really cut down on the time.
Yeah, absolutely. I've experienced that with the cage, where people say, oh, we're required to use the cage. It really only looks at the highest end of the spectrum, and they don't know why or who required it, and they go in and talk to the in charge, and they say, oh, we don't have to use this. Let's look at some other things. And so, it opens up the opportunity to use the audit and the DAS and these others. So if folks are interested in any of those tools, I can tell you where we have copies of those. The adolescent tools, the CRAFT and the S2BI, are posted on the SBIRT.webs, that's plural, SBIRT.webs.com. There are copies of those tools available. And also we have copies of the audit for adults, because they can be used with young adults as well as adults, and some other tools there. You'll find it in the resources section. And there's some other tools like the APA emerging measure, which is based on the assist that Pam mentioned. They're up there. Take a look. And they're in the public domain, or we've gotten permission to use them. So let's look back at some of the other questions here. We have another question about documentation of the intervention. So how are you documenting the interventions that are received? Is it a yes, no click in the EHR, or are there more details to indicate what really occurred, what type of brief intervention or referral to treatment?
Yeah, thank you for that question. That's an important one. So, I think what we've seen most often is minimally a yes, no, was a brief intervention done? And that's useful because we want to know if the screening results indicated that the person is at an elevated risk. Best practice, according to the SBIRT model, is that a brief intervention be done. And so if we don't have a way to track whether yes or no, then we don't know if we're really truly doing the model. So minimally, being able to track that is important. Some groups I've seen, at least early on, they wanted to gain some traction in feeling like they're doing good quality brief interventions. So we had one organization that followed the model, we just blanked on it. Well, there's multiple ones. There's FRAMES, so that's an acronym that stands for feedback and several steps. There's FLOW, and then there's the BNI, or the brief negotiated interview. So what I was getting at was one group took one of those and they took the brief negotiated interview, and there's 4 steps. They put that into their electronic health record and wanted their clinicians, this was a mental health setting, to document that they did each of those steps. And so not just did you do a brief intervention, but what did the brief intervention consist of? They're not sure that's going to be sustainable because that asks for more clicking and more, but they wanted to start there so that their clinicians were really specifically following the pieces, right? So bringing it up and talking about the screening results, and providing feedback, making sure that they reviewed and discussed what the score meant, eliciting, enhancing the person's motivation to make a change, and then having a plan in place. So that's another way to do it. The other way I would say I've seen most is, was a brief intervention done, yes or no? And what is the goal or the plan? So that you have something both to track and when you do your follow-up to say, hey, last time we talked about you plan to, not smoke pot every day, but, only 2 days out of the week. harm reduction, right? So that might be something worth tracking, because then at the next visit, it's a quantifiable thing, and it's a source of the conversation to stay accountable to helping that person meet some goals and reduce their use.
Yeah, that's very helpful. This is a question I find comes up quite a bit in terms of the documentation, so I can really appreciate Donica's question and your response. And those models, like you were mentioning, flow and BNI and frames, a lot of them have core elements, and even at a high level, those could go into an EHR, and they could be ways of trying to helping with fidelity and seeing if those components of that model are touched on, and that's a way of documenting that it's occurred. And we did webinars in this series several years ago looking at that. We have them on demand also on the hospital SBIRT.webs.com website. Folks in Oregon had done a lot of this because they wanted to be able to document sufficiently and then be able to connect it to billing. And so we've done some webinars on this topic, and I found that it's not just for documentation. It actually helps the provider, like you said, see where they're going in that model, in the flow, hitting the BNI steps. And sometimes there's scripting in there. Have you seen scripting? Has that been something you found that's particularly helpful to help the practitioner, really remember what goes into the BI?
Yeah, I think that's never a bad thing. I think having some framework or model, I've been in projects where we didn't really define what the BI needed to be, but that it was, a conversation about reducing use. But that isn't defined enough for a lot of providers, and we don't know what that really looks like. So having some scripting and having some framework required, I use that term, lightly, but at least initially, as providers are getting comfortable and familiar with how to do this and to do it well, I think is really valuable. We've also had some providers that, at least within their case notes, they will describe what came from the brief intervention. The only thing with that is that's not always mineable data, right? Someone's got to go back and read that because it isn't in specific fields. So you have to think about whether you would want both, tracking in fields that you can pull that data from, or do you want a narrative so that you're at least on a maybe a supervisory level, the supervisors reviewing those case notes so that they can be coaching or talking with their staff about how they're doing those brief interventions.
Well, great. Well, thank you. Thank you. I'm going to take one more question here. Jerry's question is, are you aware of any mental health programs that have implemented SBIRT, and if so, how have they worked?
So I'm not sure what he means by mental health programs. I mean, we've definitely seen a lot of mental health centers implement SBIRT. A lot of the SAMHSA grantees that I referred to in that article were mental health providers or centers. Do you interpret something more from that I'm not catching?
Well, I might encourage Gary to reach out to you, and because you have experience working in these mental health, or working with folks in the mental health centers, and you may be able to share some more detailed information about some of the models that you've seen or how it's worked. And so, Gary, I'll encourage you to reach out to Pam directly, since she's, probably has a lot more that she can even describe here. But yeah, I think that's probably the best way.
Great. Yeah, happy to do that.
Okay, great. Well, I didn't get to all the questions, but I would encourage folks, if you do have a question that is a burning question you'd like more information about, Pam's been very generous in providing her contact information. And so I want to thank you, Pam, very much for such a rich webinar, sharing a lot of your experience. You have lots of it to share. We'd love to have you back in the future. And in our last few minutes, I just want to point everyone to where they can find the PowerPoints, as I know people are asking, where can I get those? Not only are they in the handouts pane, but they're also on the website. And you will also be able to request a certificate of completion for your participation in today's webinar. The application Misty has posted in the chat box. You're going to see that you can fill out the application, and you'll be able to also request, once you get your request in for the certificate, you'll also get the continuing education information, which is the 1.5 NADAC CEs. In order to do that, we ask you to complete the survey, the short online form that Misty has posted in the chat box. If you could complete that first, that would be your first step, as well as the evaluation. It's a very brief evaluation that we do, and it's really important to our team and to SAMHSA to really understand how you feel about the education that we provide you, and it's really key to maintaining our funding, and it helps to see how we're doing. So we appreciate you completing that and then completing your CE certificate form. Also, the on-demand webinar will be on-demand recording, which will then be posted to the same place where you can find the PowerPoint slides. That will be there. And anyone who wants to go through the on-demand recording, we encourage you to share it, let folks go through it, complete the evaluation survey after they go through it, and then they can also complete a certificate of completion. So you can get that both for your live and the on-demand learning. You'll also be receiving a follow-up email, and so it will have some of the key information I just reviewed with you and a reminder to where you can link to all those materials. And last but not least, if you have any questions about today's webinar or other webinars or other information that might have been discussed today about the tools or any of the models we were throwing at you, or you just have general questions about SBIRT implementation or evaluation or training, you're welcome to schedule a free technical assistance call with me. You can just reach out to me directly, and we can set up a time to chat. And last but not least, I want to thank everyone for attending. Thank you, Pam, so much. Really appreciate you being here.
You're welcome.
And yes, and I appreciate all of the collaboration between the National SBIRT ATTC, NORC, and the BIG initiative. And I encourage everyone to take a look at our website and access all the free resources, materials that are there. So thank you, everyone, for joining us, and I hope you will join us in June for our looking at screening and brief intervention with gambling in military populations. And I hope everyone has a good day.